Alright, now on to one of the most important topics of gastroenterology, gallstones. Now, gallstones are super common and should be on everyone's top 10 list every time a person comes in with upper abdominal pain. In GI anatomy, we go into a little bit more detail about the anatomy of the biliary tree and talk a little bit about how anatomic level influences pathology. In this section on gallstones, we go into a little bit more of a deep dive on this important disease process. To start off, there's two main types of gallstones, cholesterol stones and pigment stones. And of the two, cholesterol stones are more common in the United States. They form in the gallbladder because the liver excretes excess cholesterol into the bile, which refluxes back up into the gallbladder during the fasting state when the sphincter of Oddi is closed. The gallbladder, in turn, concentrates the bile and stores it for release. Now, as you may have realized, cholesterol is not water-soluble, and pretty much by definition, every fluid we secrete is aqueous, even ones filled with oil like bile. So it's not really that surprising then that cholesterol has a tendency to precipitate out of the bile, seeing as it's not really water-soluble. And when the gallbladder attempts to increase the concentration of cholesterol by concentrating the bile, it only makes matters worse. So, how come cholesterol isn't precipitating out of the bile literally always? Because arguably, the most important functional components of the bile salts, are specifically there to allow lipid droplets to exist in harmony inside an aqueous medium. These are supposed to keep the cholesterol soluble even at very high concentrations. So you might be asking yourself, if there's this whole system in place, how come cholesterol is able to precipitate out of bile solution and form stones? Well, a lot of it has to do with the ratio of cholesterol to bile salts. The more cholesterol and the less bile salts you have, the more likely a stone is to precipitate out of solution. Another major factor is low gallbladder motility. If bile hangs out in the gallbladder for too long, the gallbladder just keeps on concentrating it, increasing the likelihood of stone precipitation. In terms of epidemiology, this creates the well-known gallstone archetype, fat, fertile female over 40. And it makes sense if you break it down. Obesity and hypercholesterolemia are linked by metabolic syndrome. Age is a pretty easy one to remember, but just remember that gallstones become much more common after age 40, not just at around age 40. Being female and fertile is actually very important. Below 40, women are 2 to 3 times as likely as men to get gallstones, but after menopause, the incidence is almost equal. Pregnant women are more predisposed to develop gallstones, and for some reason, every time a woman becomes pregnant, her risk of developing gallstones increases further, even after the baby's delivered. At a molecular level, this may be partly because estrogen alters cholesterol metabolism to promote excretion of cholesterol into the bile, whereas progesterone not only decreases bile salt synthesis, but also relaxes gallbladder smooth muscle, kind of like it relaxes most of the other smooth muscle in the body. So actually, exogenous steroids like oral contraceptives will also increase the risk of gallstones. So the 4 F's are pretty well known, but ethnicity also plays a pretty big role in gallstone development too. Native Americans, interestingly enough, have the highest prevalence of gallstones, and the best example is the Pima people of Arizona, who have like a 75% prevalence of gallstones in women over 25, or something ridiculous like that. Finally, rapid weight loss is also associated with gallstones, and the reasons are multifactorial and probably more than you need to know for the test. Now, the other type of stones, pigment stones, come in 2 different flavors. Black, which is usually made of calcium bilirubinate crystals, and brown, which signifies a chronic infection of the biliary tree. Now, black stones, which require high levels of bilirubin to form, generally require unconjugated bilirubin to develop, and the reason that it needs to be unconjugated is because the process of conjugation makes bilirubin extremely water-soluble. And in general, bilirubin does need to be conjugated before it can be excreted. But when there's a massive overload of unconjugated bilirubin trying to get into the bile canaliculi, there are some partially or completely unconjugated molecules that manage to make it through. Which of course is a huge problem, since not only are they not water-soluble, they also don't play nicely in micelles like cholesterol does. So they end up forming crystals with calcium that end up precipitating as these hard black gallstones. So what causes unconjugated hyperbilirubinemia? The most common etiology of black pigment stones is chronic hemolysis. But another very important etiology is cirrhosis, and the reason may not be initially obvious. Because cirrhosis does cause mixed-type hyperbilirubinemia, usually erring on the side of conjugated. However, the functional hepatocyte mass capable of excreting bilirubin in a controlled manner also decreases. And while there's both unconjugated and conjugated bilirubin waiting to be transported, the conjugated bilirubin's more content, chemically speaking, just to stay dissolved in the blood and stay in systemic circulation, while the unconjugated bilirubin is more inclined to diffuse through membranes into the bile canaliculi. And that increased proportion of unconjugated bilirubin tends to be enough to precipitate black stones. So while cirrhosis is most closely associated with black stones, it also does increase the incidence of cholesterol stones. Just as the decreased synthetic functional liver parenchyma means decreased conjugation of bile, it also means decreased synthesis of bile salts and more estrogen, both of which are risk factors to cholesterol stones. Biliary and GI stasis tend to encourage stone formation, partly because of increased concentration time, like with cholesterol stones, but partly because GI stasis increases enterohepatic resorption of bilirubin, something you actually see a lot if people are on bowel rest or total parenteral nutrition. And finally, Crohn's disease is associated with both black and cholesterol stones. Brown stones are a really uncommon type in the United States, but are actually really common in Asia where the prevalence of cholesterol stones is low. It's caused by bacterial infection in the biliary tree, usually chronic infection as opposed to acute ascending cholangitis. The weird thing about these is that, unlike the other two, they don't always form in the gallbladder. Cholesterol and black stones are caused by the presence of barely soluble substances in the bile. So when they reach the gallbladder and when it attempts to push the bile past the point of saturation, boom, you get a stone. But with brown stones, there's no problem with the composition of the bile. The stone forms near the areas of bacterial colonization as they convert lipids to less soluble metabolic byproducts. This, by the way, is one type of gallstone that a cholecystectomy doesn't usually fix, since they form outside the gallbladder. So tell me then, if gallstones are so common, if there's a million reasons to have one, then how do you know if a person has gallstones? If you said right upper quadrant pain or postprandial pain or even Murphy's sign, I applaud you. In general, you should always assess your patient to be a doctor before jumping straight to labs and imaging. But no, that's not the right answer. The question is, how do you know if somebody has gallstones? And the fact of the matter is, a whopping 80% of people with gallstones have never had a gallstone-related symptom in their life. So the only way to know for sure whether or not someone has stones in their gallbladder is to do imaging. And what kind of imaging is considered gold standard for imaging gallstones? The CT scan, which is used for most other abdominal pathology, will actually miss a lot of stones, as a lot of these are not radiodense. And because when you get right down to it, CTs are really just 3D X-rays. The black stones are always radiodense. The brown ones are almost always radiolucent, and cholesterol in general is radiolucent, but about 10 to 20% of them have these calcifications that allow you to see them well on CT, or plain radiograph. So the test of choice ends up being the abdominal ultrasound, which has a really good ability to distinguish between the liquid bile and the solid stones. Now, does this mean you go in cutting the gallbladder out of every single person you happen to find a stone in? Not at all. In general, asymptomatic cholelithiasis is not an indication to perform a cholecystectomy. It's got a low incidence of progression to a serious complication requiring surgery, and if it's not bothering you, why go through surgery? It's only when gallstones start causing complications that you start considering surgery. Gallstones cause symptoms when the stone is near the neck of the gallbladder. When you eat a meal with a lot of fat and protein in it, the duodenal eye cells recognize that the meal is going to need a little extra preparation before it can be served up to the intestinal enterocytes. So, like an Iron Chef, the eye cell coordinates the preparation of the meal for consumption by signaling to the gallbladder and pancreas with a hormone known as cholecystokinin, or CCK. And this hormone's effect on the gallbladder is right in the name. If kinin, like kinetic, implies movement, then cholecystokinin is going to make the gallbladder squeeze, unfortunately pushing that stone right up against the neck of the gallbladder. The pain of a gallbladder squeezing against a fixed obstruction is called biliary colic. The pain, like liver pain, is in the right upper quadrant or epigastric area, and it's often associated with nausea and vomiting. In general, unlike a lot of the other serious biliary pathology, the labs are often within normal limits, but an ultrasound should be able to visualize a stone. Most of the time this is self-limiting. In about 30 minutes to 6 hours, the stone either passes through the biliary tree or more commonly just falls back into the gallbladder once it relaxes. And everything's all good. Except now, you've gone from asymptomatic to symptomatic, and that means you're a candidate for elective cholecystectomy. And you may be asking yourself, if the episode resolved, then why the heck would I want to go to surgery? Well, the first reason is because many patients who get biliary colic will continue to have episodes of biliary colic. The second is that while the vast majority of gallstones never develop serious or life-threatening complications, developing symptomatic cholelithiasis increases your rate of developing those complications. Elective removal of the gallbladder for intermittent or even a single episode of uncomplicated self-terminating biliary colic is primarily indicated to prevent some of the major complications of a gallstone impaction. And surgeons, just to give you an idea, surgeons strike a delicate balance with prophylactic surgery. On the one hand, the operation's technically a lot easier and more complication-free when you're not trying to operate around organs that are acutely inflamed, friable, surrounded by adhesions, and inclined to spill infected fluid everywhere. On the other hand, they're recommending invasive surgery for something that's not even a problem yet. Surgery itself has inherent risks of complications even in the best case scenarios, and operating for a problem that doesn't even exist is emotionally a tough sell for a patient, many of whom are afraid for surgery. The rest of this section, however, is going to be dedicated to the complications of cholelithiasis that generally require urgent or emergent intervention because of the morbidity and mortality risks associated with them. Let's take a look at some of these complications now. By far the most common complication of gallstones is acute cholecystitis. And usually the way this happens is that a stone gets stuck in the neck of the gallbladder or in another part of the cystic duct such that it can't be pushed farther down the biliary tree, but it's too far in to fall back into the gallbladder like with biliary colic. Then, if the irritation from the stone is sufficient, it sets off an acute inflammatory response proximal to the obstruction. Symptoms are pretty similar to those of biliary colic, but the pain doesn't quickly resolve like in biliary colic, and the inflammation from the gallbladder can irritate the diaphragm, causing referred pain to the shoulder. The classical physical exam feature present in acute cholecystitis is Murphy's sign, and no, this is not the same as right upper quadrant tenderness. To elicit Murphy's sign, you place your hand in the right upper quadrant and actually hook your fingers under the ribs, like so. This brings you close to the anatomic position of the gallbladder, so next you ask him to take a deep breath in, pushing the diaphragm and, by default, the liver and gallbladder towards your hand. Because this essentially squishes your inflamed gallbladder, it puts these patients in a world of hurt. But the definition of a positive Murphy sign is that their inspiration must involuntarily stop secondary to pain. It's very sensitive, but pretty nonspecific, and really, any type of biliary pain can cause a Murphy sign. It's just most characteristic of cholecystitis. So there's no lab finding that's specific for acute cholecystitis. You'll usually see fever and leukocytosis, but these are pretty nonspecific. A common misconception is that you'll see elevated liver function tests with cholecystitis. That's actually false. ALK Phos and GGT, the ones that are most commonly associated with biliary pathology, are marked as a damage to the hepatocytes surrounding the bile canaliculi, and in cholecystitis, the inflammation is simply restricted to the gallbladder. If you see elevated ALK Phos, you should be suspicious that there may be a more distal process going on. The diagnosis of acute cholecystitis is made with ultrasonography. You'll be able to see the gallbladder wall thickening or fluid surrounding the gallbladder, as well as the gallstones you'd normally see in biliary colic. CT can make this diagnosis too, but for the reasons we discussed, ultrasound is preferred. If the ultrasound or the clinical picture is non-diagnostic, a much more expensive study you can order is a HIDA scan. Basically, a radiotracer that's specifically excreted in the bile is administered IV, and this is initially taken up diffusely by the liver. You can follow the tracer as it's secreted into the hepatic duct, flows down into the common bile duct, and then backfills into the cystic duct and gallbladder. If there's a stone, you'll see the secretion take place, but the gallbladder won't fill past the obstruction. The other advantage to a HIDA scan is that you can diagnose weird stuff a little better, like functional biliary colic, where the gallbladder won't empty normally. So, this is how most cholecystitis works. There is, of course, the odd occurrence of acalculous cholecystitis that you see in really sick patients. Same findings of wall thickening and pericholecystic fluid on ultrasound, but there's no stone. Now, the cause of gallbladder inflammation is multifactorial and may be related to a combination of stasis and global hypoperfusion of the GI tract, but it's not well established. But no matter what the cause, the treatment for cholecystitis is urgent cholecystectomy within the next 24 hours. One common misconception I hear a lot is that cholecystitis is an infection of the gallbladder, which isn't necessarily true, but it's one of the complications associated with letting the obstruction just sit there. Because stagnant bile is a great breeding ground for ascending infection, and that can lead to sepsis pretty quickly. So even though cholecystitis can actually spontaneously resolve, nobody likes to take that chance. The pressure from a backed up bile or stone can also perforate the gallbladder, leading to peritonitis, and perforation and infection often go hand in hand. Less commonly, the perforation will create a fistula between the gallbladder and the gut, which relieves the pressure, but can lead to weird radiographic findings of pneumobilia, or GI air, in the biliary tree. And just like GI air can enter the biliary tree, stones from the gallbladder can enter the GI tract, leading to a very uncommon but kind of cool pathology known as gallstone ileus, where a stone that travels through the fistula actually causes a bowel obstruction at the most constricted point between the duodenum and the anus, namely the ileocecal valve. But these are all bad outcomes of acute cholecystitis. We tend to recommend cholecystectomy because surgery is generally safer than watching and waiting. But in many cases, patients have recurrent attacks of biliary colic or even acute cholecystitis that's not quite severe enough for them to come in. And this regular irritation can lead to a chronic inflammatory process called chronic cholecystitis. Not only is chronic cholecystitis more commonly associated with the formation of enteric fistulas, if GI pathology's taught you anything, it's that chronic inflammation tends to lead to cancer. There's a particular marker of chronic inflammation easily seen on CT, an eggshell-thin layer of calcium in the wall of the gallbladder that's known as porcelain gallbladder. Having a porcelain gallbladder doesn't actually lead to any symptoms, but if you see one incidentally on CT, these individuals need surgery referral for elective cholecystectomy because their risk of gallbladder cancer is much higher than in the general population. Fun fact for you future surgeons, if you've ever seen a laparoscopic cholecystectomy, you might realize that removing a porcelain gallbladder laparoscopically would be technically a pretty challenging thing to do. You're trying to grab this hard, brittle gallbladder with tiny graspers on a stick that's meant for handling tissue, and then you have to deal with the issue of how the heck you're going to get this thing out of a keyhole-sized incision because a porcelain gallbladder can't squish down like a normal gallbladder. If a stone happens to move from the cystic duct to the level of the common bile duct, this migration marks a significant change in pathology. And why is that? Remember, the gallbladder is just a repository for bile. There's no major functional problem if it's cut off from the common bile duct because the liver can still secrete bile into the biliary tree. Whatever needs to be excreted is still excreted, and the digestive function of bile is preserved, albeit in a less controlled manner. And that's the reason you can perform a cholecystectomy with relatively few issues long term. When you obstruct the common bile duct, you completely disconnect the biliary tree from the GI tract, meaning that the digestive fluid that needs to get to the GI tract can't get there, and waste products that are supposed to be excreted reflux back up into the biliary tree and into the systemic circulation. The GI consequences of a lack of bile are pretty self-explanatory. Bile aids in fat digestion, so obstruction of the CBD causes decreased ability to digest and absorb fats and fat-soluble vitamins, and the slightly more disgusting corollary that if it's not absorbed, it gets released by the body in the form of oily stools and occasionally oily flatulence. Apparently it's harder to hold in oil when you're trying to pass gas than it is to hold in stool, but I wouldn't know. Bilirubin, the metabolic waste product of heme degradation, can't be released into the stool, causing it to turn this very off-putting, colorless grayish tan color. Meanwhile, the bilirubin that was conjugated and sent out by the liver refluxes back up into the biliary tree, causing jaundice and dark urine. These patients also get hyperlipidemia because now they've lost the body's exit point for cholesterol. So these patients will still probably have right upper quadrant pain and all that jazz, but the symptoms usually are less pronounced than in cholecystitis or biliary colic because the gallbladder isn't as directly obstructed. Its pressures equalize with the pressure of the entire biliary tree, proximal to the obstruction. But while the gallbladder's out of the hot seat, the hepatocytes start to suffer. See, the gallbladder's got a relatively thick muscular wall, and the bile canaliculi are delicate and easily ruptured. Furthermore, bile's pretty irritating to cells, and when the bile spills out into the liver, you start to see elevations in liver function tests, particularly alkaline phosphatase and GGT, because they're specific to the cells surrounding the bile canaliculi. This pattern of labs, or elevated conjugated or direct bilirubin, elevated cholesterol, and elevated transaminases with disproportionate elevation of alk phos and GGT, is called an obstructive, or a cholestatic pattern of lab findings, and is found in every disease process that primarily prevents biliary outflow. Because the implications of a gallstone in the common bile duct are so unique, this disease process is given a specific name, choledocholithiasis. And this is a major physiologic problem and requires urgent removal of the stone. The good news is, the common bile duct's distal enough of a location to where it's accessible to gastroenterologists, and can be removed in a less invasive way and with fewer complications than having a surgeon pick at that tiny duct with his fat fingers. It's called endoscopic retrograde cholangiopancreatography, or ERCP, and it's a little like interventional cardiology or radiology done through an endoscope. You put the endoscope down until you see the sphincter of Oddi, but since the biliary and pancreatic ducts are way too small to put a camera through, you just thread a little catheter up through the ampulla of Vater, and from there you switch to fluoroscopy, and find your way through the duct by shooting small jets of contrast and seeing where the contrast stops. When you know where the obstruction is, you can thread a wire past the stone, then inflate a balloon distal to the obstruction. Afterwards, you can drag the stone out using the balloon to sorta hook it. It's a pretty nifty trick. You can even stent open ducts if they have strictures or if there's cancer obstructing the duct. But back to stones. You're going to want to follow the ERCP up with a cholecystectomy at some point. Just like with symptomatic gallstones, the patient does need to have a cholecystectomy performed at some point. Choledocholithiasis has two major complications that you need to know about, and both of these can be pretty nasty. If the stone migrates all the way down the common bile duct, it still has the potential to get stuck at the sphincter of Oddi, which makes sense because that's a natural point of constriction. But unfortunately, this is a really bad place for the stone to get stuck. If the stone's in the ampulla of Vater, that means that you have impaired outflow of both the biliary and pancreatic trees. And let me tell you, the pancreatic system does not like to get obstructed. This leads to what's known as gallstone pancreatitis, one of the most common types of pancreatitis, and it's essentially a combination of choledocholithiasis and pancreatitis. We'll talk more about that one on the section of pancreatitis. But the other dangerous complication is ascending cholangitis. Much like cholecystitis predisposes to infection of the gallbladder, choledocholithiasis predisposes to an infection of the entire biliary tree. And this is quite a bit worse, because the pressure of the obstruction ruptures bile canaliculi. And when the bacteria ascend the entire stagnant biliary tree, the entire liver becomes open to them. Just picture that for a moment. There is a pressurized, nutrient-rich broth full of bacteria that just gets spewed up right in the middle of a structure that gets 20% of the cardiac output at baseline, and basically just dumps straight into the systemic circulation. Needless to say, ascending cholangitis has an extremely high risk of causing E. coli bacteremia, and some of the most aggressive cases of septic shock around. There's another one of those stupid classic presentations that you're supposed to memorize, this one by a dude named Charcot. The Charcot triad is jaundice, right upper quadrant pain, and fever, which you may recognize as regular old choledocholithiasis plus fever. Then a guy named Reynold realized that this was a stupid way to define cholangitis, so he attempted to make it a little less stupid by adding 2 other criteria and calling all 5 Reynold's pentad. Shock, because septic shock is really common in ascending cholangitis, and altered mental status, which tends to happen when you're in shock or severe sepsis. I bet Charcot was mad about that. Alright friends, so that's all about gallstones. It's a pretty long section, so let's see what you remember after a flash quiz. The question is, which gallstone-related pathologies usually increase alkaline phosphatase? Go ahead and pause the video if you need to think through this one. The pathologies that increase alkaline phosphatase are the ones that cause distal obstruction, namely obstruction of the common bile duct. That includes choledocholithiasis, gallstone pancreatitis, which is really just a specific kind of choledocholithiasis, and ascending cholangitis. Cholecystitis usually doesn't cause elevations in alkaline phosphatase, and if it does, it may be starting to involve the common bile duct.